Welcome to the Healthy Lifestyles Podcast, located here in Northwest Phoenix, Glendale, and Peoria. My name is Dr. Nick Hunter. I'm a doctor of physical therapy, and I own and operate Preferred Physical Therapy, where we have helped hundreds of people aged 40 plus stay active and independent, live free from painkillers, and avoid surgery, even if they've had pain for years. I've written over 8 ebooks on how to treat common injuries and hosted numerous webinars, all in an effort to help educate the public on how to care for and maintain their bodies to live with joy, dignity, and without compromise. This podcast is intended to help you make better decisions about your health so you can find joy in the journey by bringing together top healthcare providers, fitness experts, and nutritionists in the area to give you the knowledge and confidence needed to make good healthcare decisions. Thank you for joining us today. And today we're excited to introduce Dr. Andrew Minkley. He is from Desert Spine and Sport and a physiatrist recently joining their team. He's focused on restoring function and working creatively with people across the spectrum of ability to help them achieve their goals. My philosophy is to treat my patients where they are and to use education on diagnosis and recovery as a way to empower them to maximize activity and quality of life. Dr. Minkley believes that movement is medicine, and that we all need a little help sometimes to feel like ourselves and return to healthy and pain-free activity. Sounds exactly in line with what we try and do. Dr. Minkley's graduated from the Medical College of Wisconsin in Milwaukee, Wisconsin. He got his bachelor's degree from the University of Wisconsin in Madison and did a residency at the University of Washington in Seattle and a fellowship at the Interventional Spine and Musculoskeletal Medicine Desert Spine and Sport physicians here in Phoenix. Dr. Minkley, it's great to have you on our program today. Did I miss anything in that introduction?
No, I think you did a nice job covering sort of my train as it has gone from Madison, Wisconsin, back to Milwaukee, where I'm from, out to Seattle, and then down here to Arizona throughout all of that extensive training. And that kind of sums up the academic side. I think from a more personal side, I'm active myself. I like to try to practice what I preach and put those things into action, on a daily basis for myself and for all my patients too.
Fantastic. What kind of things are you into? What do you do to stay active?
I have my long-term passion has been basketball, though I was battling an injury last year that took me off the court for a little while. My current, we'll call it challenge, is a cross-country ski race that happens every year in northern Wisconsin. So
Okay.
I'm currently trying to train for this cross-country ski race while living in the desert in 100-degree heat. So that's proving a challenge, but building up some general endurance is I think going to be helpful once I can strap the skis on.
Absolutely. So how far is this cross-country race?
So the one I'm doing is the half. It's called the Kortolopit, which is 19 miles, I believe, 19 point something. The full runs about 30 miles from Cable, Wisconsin down to Hayward. And my family's had a cabin in that area for a long, long time. And I've never been up there this time of the winter, but this is a ski race that's been going on for 50 years. So I'm finally doing it this year.
That's exciting. And how long do you anticipate it to take? 19 miles on cross-country skis doesn't sound fast, but I'm not as familiar with cross-country skiing as other activities. So
it's a great question. Yeah, it's a great
We're
question.
going to find out.
We're going to find out. I've really never done anything like this before. I think the fastest people finish it, the 19 mile, in about 2 hours, two and a half hours, something like that. Maybe a little bit faster than that. I think it's probably faster than running. So
yeah, it is a little faster than marathon for sure.
Yeah.
Okay. A few miles short. Well, great. Well, now tell us what you're passionate about. What got you into this work as a physiatrist? And let's just back up. Can you explain to us, what is a physiatrist? What does that distinction mean, and how is that different from an internist or cardiologist? Like, what does that mean?
Yeah, I think that's such an important question. It's one that we battle with as physiatrists all the time. Even other physician specialties don't always know what we do. And I think it's important for us to kind of, stake our claim as where we can be most helpful. physiatry came out of World War II, actually, with a lot of disabled veterans that were coming back home. So it initially started with rehabilitation care for amputees and patients with spinal cord injuries, veterans with spinal cord injuries, and then kind of grew from there. As physical medicine and rehab doctors, we're focused on function. We don't own one organ system. We don't own the heart or cardiovascular system. We don't own, the brain per se, or the nerves like neurology does. But we kind of interlay all of that together, and generally it's a combination of neurology and non-surgical orthopedics, with a focus on improving function and quality of life. So right now, it's a sort of a cross, but mostly pain medicine, musculoskeletal medicine is the subspecialty field that I am practicing in.
So when would a patient seek out a physiatrist? Tell us more about some of the conditions or the background of a patient you typically see that would be a good candidate to seeking care from someone like you.
Yeah, I think, our bread and butter, especially here in our practice, Desert Spine and Sports, is the spine. And so you're talking about herniated discs, spinal stenosis, which is narrowing around the nerves in the spine, arthritis of the spine, pinched nerves coming out of the spine. All things like that would be, right up our alley. And that includes, chronic neck pain, chronic low back pain, and then really musculoskeletal pain. So pain in joints, tendons, all around the body. And we try to work our way up from, the most conservative things that we can do, least invasive, all the way up through step by step, without jumping right to surgery.
Fantastic. So that clarifies quite a bit. A lot of folks thinking about suffering with back pain, particularly back pain, neck pain, any kind of spine pain, are folks who will go to their typically the way it goes is they'll go to their GP, their general practitioner. They'll get a referral for usually pills and rest. If that doesn't go away after a few weeks to 6 weeks, then they go back in and say, hey, that didn't help. And then it's usually a physical therapy or chiropractic consult. And then if it continues to escalate, it's MRI. And then after the MRI, then it's a spine specialist. And is that where you come in? Is that kind of where you should be inserted?
Yeah. And I think in an ideal situation, I would argue that we come in sooner. And this is a conversation that I have with a lot of internists across the Valley. As we move out to the West Valley and I'm going out face-to-face meeting a lot of the internal medicine docs that don't have a lot of time to evaluate these things in their 15-minute visit with 10 different things on the agenda. Yeah. And so for them being able to refer out a little bit earlier, just, at that first mention of, hey, this isn't working, 2 weeks out, pain's been there for 2 weeks, send them to us. And then what we can do is we can drive the physical therapy. Part of our practice model and part of what we do really well is communicate and talk to the physical therapists like yourself, go back and forth and try to figure out what's working for this patient, what's not. And if you need to escalate care and get imaging, or if there's anything else concerning, then we can do that. But it helps to get us involved a little bit earlier, I think, than waiting down the line, though we're happy to jump in at any point.
Yeah, I think that's a great comment, because too often we see where there's a delay in care. Like, one of my most frustrating recommendations from general practitioners is to go home, wait and see, rest and pills, because the science behind rest and pills is not good for back pain, particularly back pain, any kind of spine pain. But we know that rest is one of the worst things to do. Staying active is the best thing to do. And once you get into get under the supervision of a more medically backed, I shouldn't say, a more evidence-backed provider on what's the best route based on the diagnosis from the patient, you stand to be in the best path to care and avoid surgery, the best path to recovery and avoid surgery. So that makes a lot more sense.
Yeah, 100%. And I agree. And it's not that the the internists or the GPs are not capable of doing this sort of initial workup. It's just that a lot of times they don't have the time and resources available to do so. Yeah. So
Totally.
I'm happy to help take that portion off their plate, because this is really what we do every single day, and it's much easier for us to do that than it is for them to do that while juggling 10 other things.
Yeah. Now, are you still considered a specialist in terms, like from an insurance standpoint, where often they need to go to their GP to get a referral to go see someone like yourself, or are people able to come see you directly?
That's a good question. For the vast majority of insurances, I believe that they would need a referral. But as always, take a look at your insurance benefits. If there's no direct referral needed, we can see patients that way. We get patients that, see us on Google or, see us online somewhere, give us a call and come in without a referral all the time. And that is covered by insurance. But there are situations where a referral is needed. And so it's really hard to give as with anything with insurance these days, it's hard to give a blanket answer, because, Medicare sets the standards and then some policies follow that and some kind of branch off and do their own thing. So really, really
Totally.
tough. But in general, the insurances will cover you without a referral.
And at minimum, they can call your office and be guided from there. But they get the insurance
100%,
information from
100%.
your office team, and
Our
then they
front
can.
desk staff is well acquainted with that and would be able to probably tell you much better than I can.
Perfect. What got you into this work? What got you so curious about taking care of people in this way?
Yeah, I think that goes back, probably started in college. I did my undergraduate degree in Madison in exercise science. And so going through that and sort of learning the biomechanics of how people move got me really interested. It's sort of the stuff that you just dig your teeth into and you get you excited,
Mm-hmm.
And then going on to medical school, I wanted to find a way to kind of put that function forward into my practice, and to be involved in something that really promotes health, not just treats illness, if you will. And I think nowadays there's a lot more ways to do that, with preventive care being really pushed to the forefront and that sort of thing. But I found my lane really with physical medicine and rehabilitation, and that focus on function, and the ability to, no matter what the injury is, neurologic or musculoskeletal, trying to rehab that and focusing less on the disorder, the disease, and the illness, and more on the capability and the ability that patients have to continue to live their life, which they need to do.
Absolutely. Interesting. So we're going to talk about neck pain, and it was a conversation that you and I both have been having around the confusion that's often surrounded with general neck pain and where people should go to next. And just in your expertise, what have you noticed are some of the main causes of neck pain?
Yeah. So kind of like you were talking about before, with it depends on when people get to me, in that, is it 6 weeks out? Is it 12 weeks out? How long is it going on? Because a lot of times, I think probably the most frequent is just muscular strains. Somebody wakes up and they have a little muscle sprain because they slept on it wrong, or because they turned their neck too fast looking over their shoulder to check their blind spot the previous day, something along those lines. Super, super common to be coming from the muscles. But then you look at what else is there, what else is in the neck, what can be causing these pain. I think the research has shown consistently somewhere between 40 and 60% of neck pain is coming from the joints. So the facet joints, these are paired joints that sit on either side of the spine and connect one vertebrae above to the one below. And so the joints are often a major source of the pain as well. And then you have the discs that sit in between those bones and the nerves. All of those can be potential sources for pain. But I think if I had to rank it, I would say probably muscular first, then joint, and then discs and nerves. What do you think?
Yeah, no, I agree with you. I think I see a lot of muscular strain either caused from disc herniation or contributing to disc, like it goes back and forth, whether the increased load and tension from an irritated muscle is then contributing to either facet joint pain or disc herniation pain. We'd like to talk about neck pain as if it's contributing to neck stiffness and immobility, so one side is harder to move toward or painful to move toward, or you're getting any kind of pain down your arm with movement, then we go into a protocol for treatment that direction. Mm-hmm. And then most commonly, I do see a lot of exercise-induced neck pain, typically strains, a lot of pulling exercises, whether that's pull-ups or rows. Surprisingly, bench press, people don't understand how their neck is involved in bench press, and the complexity that exists between neck and shoulder and how the two need to be cared for so delicately, or rather so consistently because of how delicate they are, is one area we see a lot of folks. To what you said, though, I get so many patients that will say, I didn't do anything. I just woke up one day and I had this pain. And it's like, yeah, we get the pinched nerve between the shoulder blades and a kink in the neck from, sleeping differently. They fell asleep on the couch maybe for a few hours, and next thing I know, their head's in a different position, and those things go on all the time. And so we see.
Yeah. Unfortunately, those things tend to resolve themselves quite quickly too, with a lot more conservative care, potentially just some mobilization, range of motion, some stretches, and some appropriate, exercises and postural correction.
100%. That's a great thing about. So I think a lot of people misunderstand spine pain, neck and back. So much of it will get better. So much of it will get better all by itself. Even so much of it will get better with just a little bit of guidance. Mm-hmm. I fear some people feel like they're plagued to suffer with back pain once they get it, and it's always going to be there. And there's just a lot of hope I want people to feel in terms of that's just not the case. There's a lot of things that can be done to treat this spine pain that doesn't have to result in surgery. But people will go on the internet and start looking at things, and suddenly it's requiring surgery to fix.
Yeah, I think the one comment I have about that is that the body is really, really good at healing itself. It takes time. We have to be patient, and we have to put it in the position to do so. But if we're able to do that and get rid of those factors that cause this in the first place, the body is really, really good at healing itself over time.
Completely agree. It's why I love what we do, and why we encourage folks to work with you guys, because of just how dedicated you guys are as a team to really help people get back on the right path of understanding how to be in the right space to heal without relying on pills, injections, or surgery. Mm-hmm. And we kind of talked about it, but not all neck pain is the same. How would you say patients can know when their neck pain is serious? Like, when would you say get a consult, get this taken care of because neck pain is serious?
Well, you can kind of break that down into how serious, right? I think serious, to me at least, means something that is really functionally impairing what you're doing and your quality of life on a regular basis, in which case I would say, yeah, absolutely, get that checked out, especially if it's lasting more than 4 to 6 weeks. Once it gets into that more subacute to chronic time frame, then it's something that potentially might not go away on its own, or you might need a little bit of extra guidance. When you talk about serious, that sort of makes us open our eyes a little bit, then you talk more about what's the role of the neck and the back, and that is primarily to protect the nerves and the spinal cord there. And so nerve damage, so weakness in particular in the arms, loss of control of the bowel or bladder, and balance issues, gait instability, being really wobbly, those are signs potentially that there's something a little bit more serious wrong, that there's a lot of pressure on those nerves in the neck, and that would definitely be more worrisome. So there's the serious, and then there's the very serious, I guess.
Yeah, we call those red flag conditions. Anytime you're having numbness or extreme weakness, where we even say, like, if you're starting to notice that you're grasping a coffee cup or mug and it's slipping out of your hands, or you can't hold on to it anymore, and it's different than the other side, significant concern. Any kind of unmitigating pain where it's no matter what position, what you do, what you take, it doesn't seem to change. Numbness, whether that's complete arm or in just certain fingertips, that doesn't change. Like the clock starts ticking of, if we don't get this taken care of, the risk of it being a permanent change gets higher and higher the longer those symptoms persist without getting care.
Yeah.
So those
one thing I would add to that too is sort of a loss of dexterity in your fingers. So
coordination,
trying to button your shirt, that sort of thing, and you just can't figure out how to get those buttons together. And you were able to do that previously, a couple weeks prior. Changes like that are certain things that you want to look out for. But fortunately, the vast majority of people never really are going to see symptoms like that. The vast majority of people with neck pain, are not going to have severe neurologic impairment or nerve damage as a result of that. And so that's a positive sign for all of us.
It is. It definitely is. And it's one of those as well that we try and help people understand the avenues of treatment that do exist away from surgery, away than feeling like they got to go and infuse or go in and take away some of the disc. There's so many treatments that exist prior to that, even if people have had neck pain for a long time. Yeah. So what would you say is, like, I know this will depend, but what's the fastest way to get relief from neck pain? Are we still doing heat and cold?
The fastest. Well, the fastest the fastest that actually addresses the underlying cause is probably a combination. If this is an active, inflamed area, would probably use some ice, potentially some topical medications that you can rub on the area, gentle mobility as you're able to, and potentially some anti-inflammatory medications in the short term to help reduce the swelling and irritation in that area. There's a number of classes of medications. When you talk about the fastest, medications probably in that category.
Right.
And we like to use medications mostly as a bridge, not as a, hey, you need to be on this for a long time. More of a, hey, you're in some acute pain right now, and we need to get you feeling better so that we can get you moving again.
I love the fact that you brought it up as a bridge, because we talk to patients often where they're sometimes fearful of taking any medications, worried about side effects or damage, or dependence is another one they're so worried about. And it's like, hey, let's go ahead and use this as a bridge. Relief is relief. Like, we need to be sleeping better. We need to be on the road to recovery. And our emotional attachment to pain is a big part of how we perceive pain. And so if we live in this fearful, anxious, can't sleep environment because of this neck pain, and we're unwilling to get some relief somehow, it's going to take longer to get better under any circumstance. So we're okay to use it as a bridge to then calm down some of these other systems to allow our body to heal more naturally, because the movement, the strengthening, any kind of hands-on technique, whatever else might be indicated as effective for your condition, can now work better because we have some of these pain relieving, whether that's medication or techniques available to us, patches or creams, things like that.
Yeah, exactly. And some of the topical medications too, don't have as significant of side effects. They have very limited absorption into the bloodstream. And so it just kind of sits right at the area where you're trying to treat, which is great because you don't really get the potential side effects or the possibility of side effects that you see with some of the oral medications. Every medication, every treatment, everything we do has a risk and a potential benefit. And in every situation, you have to weigh those risks. But I think if someone is really coming to you in acute severe pain, enough for them to come into your office, to come into the clinic and tell you about it and say, hey, this has been really bothering me. It's been keeping me up at night. I think it's appropriate in those situations to really use the anti-inflammatories, possibly some muscle relaxers, And if there's a pinched nerve going on, potentially some of the nerve pain medications like, gabapentin, Lyrica, those types of things, those often have more side effects in the realm of making you feel kind of drowsy or sleepy.
Mm-hmm.
And sometimes we can actually use that to our advantage at the beginning by having the patient take that at night, 30, 45 minutes before you go to bed, and it can actually help
sleep, get some rest.
Yeah, 100%.
Awesome. What would you say? I get this question often, and maybe you have an opinion on it, but I get the mattress and pillow question all the time. What's your answer? I got back pain or I got neck pain. What kind of pillow, what kind of mattress should I use? What answer do you give to your patients regarding that?
I have not found a perfect answer for that. There's no one size fits all to that, but
Yes.
I think what I tend to tell people is first look at how do you sleep? Are you a side sleeper or are you a back sleeper? And then look at the position of your neck when you're sleeping. I think a lot of times pillows are too built up. And so you end up sort of either if you're sleeping on your back and your pillow is underneath your neck, the back of your neck is stretched forward a little bit like this. And that puts a little bit of increased pressure potentially on the discs there for a long period of time while you're sleeping. And then if you're a side sleeper, if you're not, if your pillow isn't the perfect distance between your ear and your shoulder, and then, how are you gonna sit with an exact straight neck for 8 hours while you're sleeping at night? I don't know. It's a tough question. I don't have a great answer to it other than you need to try some things out. But generally, I've found that the pillows are too much as opposed to too little.
I completely agree with you in terms of there's no easy way to answer that question without asking more questions in terms of sleep position. How do you start out in sleeping is often how I will question them, because there is no perfect mattress or pillow for any one person, but we do get an investigation. So from an ergonomic standpoint, just like there are proper ergonomic and posture positions for standing and walking, there are for sleeping. And because we move around unconsciously when we sleep, we say, okay, how do we start? And what position do you get into as you start to get into bed? And that's one where we discourage using too many. If you're sleeping or if you're reading or watching TV and you're propped up and then you don't make the adjustment to go back down, we say, don't get in those positions at all. There's no TV, no reading in bed. Like you're laying down and you're getting in your spot that's going to be most comfortable and more ergonomically sound. So I completely agree with you, because so often it's prolonged neck flexion when they lay on their back, and then it's poor posture, either not enough pillow or too much pillow, that causes problems in side lying. Mm-hmm. And I try and tell everyone not to sleep on their stomach. I don't know if you're okay with that, but I have found a lot of back pain issues and neck pain issues because of how much forced rotation, because they're on their side, that people get into, as well as the extension for their back that typically cause problems. So I try and discourage them. I'm okay with like a 3/4 like side stomach, but not fully on their stomach, particularly with a pillow.
I would agree. I don't see that many people that tell me they sleep on their stomach anymore. I haven't had anyone tell me that in the last several months. So maybe the word is getting out on that. Who knows?
God, let's hope. Let's keep spreading it, because it is one concern I have. All right, good. How about in terms of how long neck pain lasts? You give us a little bit of a breakdown, even from a patient journey perspective. We talked about that a little bit, from how that typically looks. When would you say is, from the neck pain, when is it the optimum time to seek care during their neck pain journey? And how long does it typically last?
Mm-hmm. If this is really the first time that you've ever had neck pain, I would give it several weeks to a month before seeking care in the absence of any, red flag symptoms that we mentioned earlier, or severe unrelenting pain, because, as we talked about, a lot of times this thing just kind of comes in waves and it goes away. But if this has been episodic, and by that I mean you had a flare of this several years ago, and then, last March it came back, and now it's back again in October, that sort of thing, you would seek care earlier in that episode. If that comes back for that third time, then it's time to go and seek care. And on the sort of continuous spectrum, meaning you start to have pain 6 weeks ago and you're still having pain, I think somewhere in the 4 to 6 week range is probably, a pretty appropriate time to start seeking out care and trying to figure out what else you can do about this.
Perfect. I think I find myself explaining very similarly. I tell folks, if it's an acute issue where you didn't have any pain before, and then you wake up and have pain, or something happened and you have pain, I say give it 4 to 7 days. And if you don't see any improvement after 4 to 7 days, then I say go see somebody. If typically of an acute phase, we start to see some improvement. We see some change to that pain. It's not as bad or moving a little bit easier after 4 to 7 days. But if it's been the exact same, like high level of pain, disruptive amount of pain, where it's hard to focus, hard to be productive, we're irritable, we're not very patient, like all the symptoms of chronic pain, because it's been so bad, then I said, go talk to somebody, like get some relief somehow. Because usually what happens is they go to their GP and it's pills and rest is prescribed. And so we try and say, go ahead and start that. Ideally, they come see you sooner, and then we can get on a kind of a more integrated approach to care. But that's usually what I say. And then it's typically around that 4 to 6 week of, we want to see some incremental or some segmental improvements to that discomfort, where maybe the pain intensity is not as bad, the movement or function is improving. I can turn my head, or I can move a little bit easier. Some folks will tell me, oh, I'm noticing it's getting better because I can get the last gulp of water or milk or whatever it is I'm drinking. I can get my head back all the way, whereas before I couldn't do that. So if you start noticing, where does that pain present, and is it getting better, or are we functioning better? And that's typically what we say. That's the time to go get it taken care of.
Yeah, and I like what you said there, and I agree with you. I think more so than the time, it's really the trajectory. Are you getting better, and is this kind of coming back down into manageable level? Or is it not? Is it just not going away? Or is it getting worse? And in those two latter examples, if it's not going away or if it's getting worse, then, even depending on the time, but, you'd be much more likely to go in and get seen sooner.
Yeah, I completely agree with you that. And then it's a matter of, we see folks who see some improvement, and then it lingers at 4 to 6 weeks, but it hasn't quite gone back to normal, but it's improved a little bit. That's when I say, then go get something done, go seek treatment somewhere, because it's one of those where you're not far away. Like, it's getting better. You're not far away from getting in the right direction. You just need some more guidance, a little bit of work, and then it's taken care of.
And I think that's actually the most common.
Right.
That's the most common timeline. It's, this happened about a month ago and it's gotten a lot better, but it's still hanging on a little bit. So then I think that's usually where we see people in the healthcare system come through the office door quite a bit. And usually, that continues to improve over the next 4 or 6 weeks after that, to a point where it's not as bothersome or not functionally limiting really at all. But I would agree. Yeah, I think that's a good timeline as a general guidance for folks.
Excellent. What would you say are some of the common causes of neck pain? Like, if we were to break down, and maybe we go by, decade of age or activity types, what would you say are some of the contributing factors to neck pain, or even some of the things that put you at risk for developing neck pain? What would be your answer to that?
There are so many things that can potentially be, included in this list, but I think one of the biggest ones is lifting, pulling, pushing, anything with your arms above your head or outstretched in front of you is liable to cause you some pain. And that's often in the form of a disc herniation or a tear in the back of the disc, just because of the way that if you're loading your arms out in front of you, that's going to put a lot of increased pressure back there. I think when it comes to, we talked about arthritis in the joints of the neck being a really major cause of pain. And the things that contribute to that over time are the things that repetitively load those joints over time. So a lot of things where people are looking up or turning their head quite a lot repetitively over and over and over again in the same pattern, especially if there is some, postural instability there, or the movement pattern is not as ideal as potentially you would want it to be. Those are some of the things I think that contribute to more chronic pain developing, but that takes decades, to really evolve.
What would you say to our arthritic type population? So one of the things that we see, so cervical stenosis, the narrowing of the central canal, which is where the spinal cord exists, narrowing of where the nerves exit out the side. And then you've got the facet joint, which are as you mentioned earlier, the kind of the paired joints on either side of the vertebrae. The vertebrae are the bony segments of the spine, and they sit and communicate one to another. I like to refer to as a chain link. You get links where each segment is responsible for some movement, but collectively they all move and produce more motion, but segmentally there's a little bit of movement there. And so we talk about this collection of arthritis. Is there anything you can do for arthritis?
Is there anything you can do about the arthritis itself? Not really. But there is a lot that you can do to help people who are in pain from arthritis.
Thank you for clarifying. I get so many folks who are saying, oh, it's arthritis, so there's nothing you can do about it. I'm like, well, hold on, time out. There's plenty we can do about it. Tell us.
And it really depends on your definition of arthritis too. You're going to see, if you take a CT scan or an MRI of your neck, you're going to see what we call degenerative changes, or, tiny little bone spurs, or a narrowing of that joint space in the joints of almost anybody over the age of 50, 55. It's a matter of whether those things are causing pain or not. And that's part of, what our job is, to try to tease those things out. There's studies where they looked at MRIs of the lumbar spine, of the low back, and some of the degenerative changes on MRI in patients who had zero symptoms, zero back pain ever in their entire life, once you get into your 70s, is up near 3/4 of the population. And so one of the things, and one of the myths about, imaging in both low back and in neck conditions is that, there's got to be a structural issue there, and that correlates directly with my pain. The reality is that the correlation there is just really bad. There's a really poor correlation between pain and the imaging findings. And it's oftentimes really, really challenging to make that connection. Now, sometimes there are arthritic joints and it's asymmetric, and meaning one side is way worse than the other. It correlates directly with your pain, and we have a perfect picture that is wrapped up with a neat little bow. But that is more the exception rather than the rule. And so it's a lot more murky. The waters are a little bit more murky when it comes to making an exact diagnosis.
I'm glad you brought that up, because we get that kind of question all the time. Like, just go in there and remove it, or go in there and fix it. And it's not that simple. There's so much complexity around a spinal segment to suggest that it's just one tissue or one lesion responsible for the discomfort or pain, when there's often a complexity of a few, like components of a few. And the study that you mentioned, we saw it as well. With, you got an MRI, 100 people who are healthy, 40 are going to come back with disc bulges, degenerative disc disease, facet joint arthropathy, all the things that we see on an MRI that a radiologist will declare as problematic, but they have got no pain. They're asymptomatic. There's no symptoms. And it's like, we can't just rely on what the image is going to tell us when they're just not consistent. They don't correlate to what's going on. They do sometimes, but they don't always. And that can be frustrating for patients who are looking for the answer, to find the solution, when it's just not that simple.
100%. I couldn't agree more. And I think the MRIs are a little bit of a slippery slope because we all want that information. We want to know what it looks like. We want to know what's going on there. But then you kind of open up a whole can of worms there where you're not really sure what you're going to find. You're certainly going to find, if the patients are, over age 65, you're going to find degenerative changes there. And you don't know if that's causing the pain or not. I've heard some people, and I don't necessarily completely agree with the way that this is stated, but I've heard some people refer to these degenerative changes in their mildest form as wrinkles on the inside. Yeah. Right. And so you hear this sometimes and you're like, it doesn't quite make sense. But in a way, you can kind of think about some of those changes that way. Wrinkles don't hurt. And these discs, they're going to lose some of their water. That's a totally normal process of aging to see these discs change and a little bit of that change in the joints. When does it become problematic? Based on imaging findings, there's not a clear cutoff. And so much of it is correlation of your physical exam in the office with how you're moving, how your pain levels have changed over time, plus the imaging findings all together as sort of an entire picture.
And I think that really helps to kind of bring us into the segment around arthritis. And is there anything we can do for arthritis? Because it goes back to the lack of clarity around the absence or presence of arthritis causing the pain. And the fact that you have arthritis doesn't mean that the pain's going to always be there. Like there is such a thing as an arthritic flare-up where the arthritis is contributing to your discomfort or sensation of pain. But it doesn't mean that it's going to always be there because there's nothing we can do about arthritis. Tell us more about why movement or why some physical agents or remedies to treat arthritis can be so effective, and rather how they treat the arthritic flare-up so that the pain or discomfort can go away even though the arthritis stays.
Yeah. Itis means inflammation. And so when you have a flare up, it's oftentimes a lot of irritation and inflammation in one of these joints that has some of that degeneration in it. And again, if it's one of those acute flare ups where you're in severe pain and your range of motion is very limited, that's where those anti-inflammatory medications can be really helpful. The topical medications for arthritic flare-ups are not quite as helpful because the penetration from the skin into the joint is just not very good. And so you're not going to get that medication right where it needs to be. So oftentimes
too superficial.
Yeah, it's too superficial. And so
good for muscles, but not great for joints.
Yeah, completely agree, except in the hands. In the hands, the joints are so superficial that oftentimes it is. That's kind of the only place where I'll recommend those for joints. But when it comes to the spine, they're just too deep in there. If it's an arthritic flare-up, usually the oral anti-inflammatory medications, occasionally steroids, but we are very, very conservative with giving steroids, especially to postmenopausal women. Given the increased risk for osteoporosis and potentially fractures, which lead to a whole host of other problems. But those are the medications when people are really, really uncomfortable that we reach for. If you're looking at more of a chronic arthritic pain in those joints over a long time that has not responded to conservative care, and you're looking at more 3 months or so of time frame here, then you can potentially talk about procedures like the radiofrequency ablation to the nerves that supply those facet joints that we're talking about.
And that's a fairly, we say minimally invasive procedure, but fairly non-invasive procedure, non-permanent procedure to help give some relief to neck pain and back pain sufferers, correct?
Yeah, so those joints have small sensory nerves that provide sensation back to the nerve roots and then ultimately all the way back to the brain. That's how those joints can produce pain. There has to be a nerve there that carries that signal back. And what the ablation does is through a needle that just goes, poke a needle through your skin, we place it right over the bone where we know that nerve travels. And then we heat that up to about 176 degrees Fahrenheit and essentially burns off that sensory nerve. that can kill off that little sensory nerve that reduces the pain over time. And that's kind of the general concept for that procedure.
And is that done under local anesthetic or is that done under general?
General, not done under general anesthetic. Sometimes you can get a little bit of light sedation for that procedure if you have sort of a high level of anxiety around needles going into your neck, which I can imagine that many people do. It's not a comfortable thing to have done, which is why, we don't just do that to everybody who walks in with a few weeks of neck pain. It's really a more advanced option for folks with arthritis pain in the neck that just hasn't gone away. One more comment I'll make about that is that in order to proceed with the ablation portion of the procedure, you have to do a test injection called a medial branch block. That little nerve that goes to the joint is called the medial branch. And that involves a much smaller needle. And that needle just goes right down to that spot. You inject just a pinch of lidocaine numbing medicine in and around that nerve. And then you get up off of the table and you move your neck around and you say either A, yes, that worked great for me. That pain that I came in with 5 minutes ago is gone. Or B, no, it didn't. And that's part of the diagnosis of how we confirm that the pain is coming from those arthritic joints in the beginning. And all these procedures are done under X-ray guidance. In our case, we do it in our office. We have a nurse and an X-ray tech and a procedure room. Some places they're done more in an operating room or a surgery center and that sort of thing.
Yeah. So you guys are able to do those in-house at your facility.
Absolutely. Yeah. It reduces a lot of cost on
so
the
it's all outpatient and it's under mostly local light anesthetic, but you go home that same day.
Absolutely. Yep.
Good. So what is something that you tell your patients every day that you wish you could just record and push play because you say it so much? What's something you wish
the
you
medial branch block spiel that I just gave you, I think is probably
that's it.
One of them. That is one, because part of it is this pain is coming from the joints, we think, but we need to confirm that with these test injections. If those are positive, meaning those relieve your symptoms, then we can go ahead and do the ablation. And it's both from a medical standpoint and from an insurance standpoint, kind of a headache to go through that whole process, both for the patient and the provider. But we try to make things as easy as possible on folks as you're going through that. Other things that I tell people almost every day and wish I could press record. I think one of the other things that I tell people, and you feel free to comment on this too, is that treat your PT like a coach. And in a lot of these situations where chronic pain has developed over years and potentially even decades, one visit to your PT a week and then doing nothing else the rest of the week is not going to make you better. And you have to really put those practices and the things that you learn with your physical therapist into practice on a daily basis, or at least near daily basis, in order to see some of the improvement. And I can see you smiling because I love that. This is everything, this is everything that you deal with on a daily basis. But that's one of those things that I just feel really passionate about, and I feel is really important, because you hear people all the time saying, well, PT didn't work for me. And it's like, well, what does that mean? What was that
more
therapy like for you? And how much of that work did you put into at home? If PT didn't work, there's a reason for that. And in the absence of any of those major red flag symptoms, it's going to help the vast majority of people.
Yeah, I so much appreciate you bringing that up, because it is one thing that, from my perspective as a specialist in physical therapy, and we deal with folks who have been to regular physical therapy. And so we deal a lot with people who have said, PT didn't work for me, or I've been to PT, I tried that, it didn't work. And a lot of it will be a conversation around, okay, well, what did you do? Oh, I did all the exercises. It's like, well, you did all the exercises. So, okay, tell me more about every single exercise that you did, because so much of the degradation or the degeneration to joints, particularly if it's posture related, and we'll get in, posture is getting kind of a bad rap of it, whether it is or isn't causing or contributing to pain. And really, it's the understanding that the best posture is your next posture. We're moving creatures. We beg for movement and mobility. And if we don't have the right balance or perspective of having both sides of our joints working well, healthy, we're gonna develop problems. And our world as humans has evolved in such a way that allows us to be specialists, to be in one thing or at one spot for long periods of time. And that can wear on us physically, from our body perspective. And we get a lot of breakdown from that way. And so recognizing that a lot of our chronic pain is contributed to these positions or movements done repeatedly over time to in a small degree of incorrectness, of bad movement habits. We call them motor programs in the medical field, where we have these motor programs that have contributed to this decline. And then our goal, like as you mentioned, as coaches, is to identify what those are and then prescribe exercises to combat that. And they often don't work overnight. That's a shocking realization that many patients, I went that one time and it didn't get better. It's like part of what we do is treatment is diagnostic. Just like your medial branch block technique is, is it going to work? We won't know until we administer it.
Right.
And that's physical therapists. Very similarly, we do prescription of movement and exercise with the intention to further identify how are you responding to that intervention, and are we needing to make some changes or adjustments? And that's why it's so important to have a PT or a PT model that allows for one-on-one time with your provider. Because without it, if they come in and say, okay, how's it going? Okay, great. You do these exercises, and then they walk away. You never see them, and you're doing exercises you could easily find online or do at your own at home. You're right. It's going to be hard to say that that's all of that helpful versus one who's going to be with you, watching the way you're moving, prescribing things intentionally, making adjustments based on how you're doing them, modifications to the dose, the reps, the sets, the load, to then say, okay, let's find a route, a path that you can perform pain-free that's going to be productive. And so very much I appreciate the comment around using us as coaches, using us as kind of that third observer, that outside party to see how you're moving and how it's impacting your condition and what we can do to make modifications around it to find success without having to rely on pills, injections, and surgery for relief.
Yeah, I think that feedback portion that you offer as a physical therapist, and those cues and those little modifications and the things that can potentially get people moving without pain is such a key portion of it. It's not just, hey, here are 4 exercises that you need to do. Here are your sets and reps. Try that out for a couple weeks. It's much more hands-on than that. And that's what I appreciate about really good physical therapists. And I couldn't do my job well, at least, without good physical therapists like you around who do this sort of stuff, because we really need to go hand in hand to help patients really maximize their outcomes here.
Yeah, I completely agree. And it does, the hand-in-hand approach is so important. I mean, when I'm able to talk to providers like yourself and give updates of like even real time, we get back and forth, day or so, but even real time of like, hey, I'm sending them back to you for this thing, or hey, this is what's going on. It's so much easier to see patients progress and get to relief as fast as possible with as little intervention as possible when we're able to do that, and it makes such a big difference. Well, yeah, Dr. Minkley, thank you so much for being on our podcast today. What's the best way for people who are listening to connect?
The best way is to go to our website, desertspineandsports.com, or you can search us on Google. We have currently 3 locations as of this podcast taping, in Mesa, in Phoenix on 24th and Indian School, and then in Scottsdale over at Shea in the 101. But we do have a Peoria clinic coming to the west side in early December, as well as a Gilbert clinic coming in early December as well. So we're going through a little bit of an expansion, but you can find all of that on our website at desertspineandsports.com.
Fantastic. And that Peoria location is going to be 94th and Thunderbird area. Tell me again.
Exactly. Yep. 94th and Thunderbird. So just west of the 101 on Thunderbird. There's quite a few medical buildings right in that area. There's a couple rehab hospitals and a nursing home right across the street. So there's a lot of medical buildup going on in that area.
Perfect.
Unfortunately, there's not a lot of physiatry out there, and so we're glad to be able to fill a little bit of that vacuum over on the west side.
Well, we're glad to have you. Thank you. We'll include some of those details in the show notes to make it easy to click on or to follow. So thank you.
Perfect. Thanks for having me.